a reality show Fear Factor. So this afternoon, we're going to be speaking about when fear replaces common sense and impacts on decision-making, patient care, and coping with our own grief. So our objectives of this afternoon is to really reflect on what fear is and to explore how it impacts on us as clinicians. As Marty suggested, we really want to try and make this as interactive as possible, but we also want to give you an opportunity to self-reflect on your own practice. Julia is going to share a few cases with us and give us an opportunity to reflect on how decision-making could have been different if the fear factor wasn't there. We're going to also then consider what are the root causes of fear and how does this impact on our performance. We'll also look at how fear impacts on our patients and families. And of course, at the end of the day, most importantly, consider the impact on our own emotional well-being. Because after all, if we are living in fear and not able to practice, that's not going to make us good clinicians. And just from the outset, we want to say that, you know, this conversation and this presentation might trigger certain memories. We're really not out here to point fingers or blame anybody for anything. We really just want to open up a safe space where people can actually participate in a shared learning. All right. So to start with the presentation and to present a little bit of theory first. So Franklin Roosevelt, just after the Great Depression in the 1930s, said that the only thing to fear is fear itself. And the reason he said this was obviously after the Great Depression, where people were going hungry, people were losing jobs, the stock exchange was crashing. The worst thing to happen was that people became so fearful that they became paralyzed and they weren't able to pull themselves out of this situation. So the fear of fear is a really important thing. And I'm going to take you through the biology of why trying to get over fear is so important. All right, so if we start off by looking at what is fear. So this is a definition, and I'll send you a link to this article, where it says that fear is an adaptive transient state, note a transient state, that's usually elicited through confrontation with threatening stimuli. So something that we see or smell or hear stimulates this state. It's an adaptive state. It's actually there to protect us. Often this fear manifests itself through emotion, and the main sort of fear center in the brain is the amygdala. And we need to compare that with anxiety. So anxiety is a tonic state, and it's often something that endures for much longer than fear does. It's also concerned a lot more with predicting things and being prepared and ready for stuff. You know, anxiety can actually serve a helpful purpose sometimes. Interestingly, anxiety is often more manifest through mood rather than emotion. And the site of anxiety in the brain is the stria terminalis. So two interrelated issues, but with different manifestations and different purposes. All right, so I just thought I'd take us through a very interesting neurobiology of fear. And we'll cover some of the fear pathways. So when one experiences a fearful stimulus, say you see something scary or you hear a noise, the brain basically takes those stimuli, and those stimuli are then sent to the thalamus. So you can kind of look at the thalamus as almost like the reception area for fear. And this dude is sitting in the thalamus and he's trying to decide, right, how much of a threat is this? Where should I send this information to? And if he thinks, oh my gosh, this is something that's really close, this is very scary, I need to respond to this very quickly, he sends the fear stimulus to down the low road. And that is the amygdala. So that stimulus is sent to the amygdala, and the amygdala connects with the primitive neurological systems, and basically that is responsible for our fight and flight process. So that's very much a primitive, almost knee-jerk kind of reaction. And the problem when this happens is that actually the higher centers, the cortex, is not involved, and a lot of the stuff that we do is very reactional, and we're not engaging the rest of our cortex. On the other hand, if we have on the orange, the high road being activated, a stimulus comes through to the thalamus says, okay, we've seen this before. This is not as bad as it could be. We don't need to really react very acutely to this. We can actually give this some thought and decide how to respond. And then what the thalamus does is, rather than sending it to the amygdala, it sends it to the higher cortical functions. Your thought processes are involved. We call this actually conscious fear. And then after the processing has happened, the stimuli go back to the amygdala, and a decision is made as to, well, is this worthy of activating the primitive fight and flight response, or can we actually deal with this in a much more rational manner involving the cortex? So I think it's actually very important to recognize how fear can affect you. And once you actually do realize this, there is actually some training that you can do to avoid you going into the knee-jerk response of activating your primitive brain that doesn't really think before it acts. All right, so is fear a friend or a foe? Obviously, there was an evolutionary role for fear. You know, when we were hunter-gatherers and, you know, we were predators for certain predators, we obviously needed this, this fear response in order to protect ourselves. So we actually owe fear the role of actually having preserved humankind. It's helped us to survive. But the problem with fear is if it induces the state of hyperarousal, it actually causes us to hyperfocus on the stimulus that is causing that fear. And when we start to hyperfocus on just one thing, we actually can't think more broadly. And then we can't actually take in any other information because this whole thing is actually consuming us. And when we're not actually able to take in further information, we actually can't make calculated decisions. So you've all heard the expression being paralyzed by fear. Because we're mostly functioning in our primitive brain, our thoughts actually feel quite muddled and very confused, you know, and because through our amygdala and our cortisol and our adrenal glands are kicked in, dopamine is at an all-time high, we actually see somatic manifestations of fear. You're all very familiar with, you know, that time that you did that first surgical procedure and you were so nervous and so scared and your hands were shaking and you couldn't even do the procedure properly. And that actually obviously leads to poor performance, and it becomes almost like a vicious cycle because then that impacts negatively on your self-esteem. You believe that you can't actually do it, and the fear just really makes it impossible for you to do your work properly and even to think about how to do it properly. So yeah, fear can be a friend, but more often it is actually a foe. Some two very interesting aspects on human fear. So humans actually experience fear indirectly. There are also some animals, especially chimpanzees, who can experience indirect fear, but it's quite a human feature of fear. So if you see in an environment that somebody else also has a fearful expression on their face, you're also going to become, or you're going to become scared. And that is actually called the contagion of fear. And I think we saw a lot of that happening in COVID. You know, you didn't always have the information directly, but you saw how other people were responding, and then you responded accordingly. Another very interesting thing about humans, we don't really know enough about whether this happens in animals, but actually in humans, fear can be provoked just by thinking about a past stimulus, something that's not currently happening, but something that is a memory that evokes fear. And that is obviously called post-traumatic stress disorder. And so that's why Franklin Roosevelt said the only thing to fear is fear itself, because it can actually cause havoc. It can cause you to become dysfunctional and cause you to become in this constant state of hyperarousal. So Franklin Roosevelt in that very famous speech went on to say that fear is that nameless, unreasoning, unjustified terror that paralyzes efforts to convert retreating into advancing. You can't get over your fear and you can't move forward. And that's definitely a situation that we want to avoid. All right, so that's just a little bit about the biology of fear. I'm now going to play a short video clip on something which is called medical fear. And this is probably something that we have all experienced. We may not have called it this. And yeah, this video will definitely probably trigger some memories. And we would like to give people an opportunity to think of times where they actually experienced medical fear and maybe identify with this speaker. All right, so I'm going to try and play this. Let's hope it works.
Medical fear is not hardwired. The things you are afraid of have been conditioned. We have learned to become afraid of things. The reason why we're afraid of things is complex. It may be from operant conditioning constant negative reinforcement, from being disciplined, from being shouted at, from just not understanding things, from seeing other people perform in a way that you think you never can. Fear then develops with a repetition to the point at which it becomes an issue. Why we're afraid is not important. It's simply important to recognize that we are afraid. Fear is real, and it affects us acutely, but it also affects those around us. We're social animals. If someone in a group yawns, you feel the need to yawn. Please don't yawn. If someone giggles, we will giggle with them. If someone in our group is afraid as a social group, we will protect that person. But we will also become aware of their fear affecting us subconsciously. And we will then start to become more afraid, particularly if that person is a senior, a chief, someone we respect. When they begin to show fear, we think there must be something I don't understand, and so I take on their fear. And the reality is that with stress inoculation therapy, we can be better performers. But the reason that things go wrong in stressful incidents is not because of a lack of training. It's not because of a lack of knowledge. The literature is clear. It's because of poor performance due to fear. Fear is real. We all have fear, no matter who we are or what we are, no matter our level of seniority or juniorness. Whatever job we do, there are things clinically that we are afraid of. And you're thinking of it right now. I'm sorry, but I think it's a good thing to think about the fear.
All right. So I want to give you all an opportunity, and I want to actually start by asking if any of you have ever experienced medical fear. And maybe you can indicate it to us just by raising your hand, clicking on the reactions and raising your hand.
Many hands are up, Michelle.
Okay, all right. Now I'm going to give you an opportunity, and we're not going to do it now. But if you have a piece of paper and a pen near you, maybe write down just 1 or 2 words about the incident that caused that medical fear. All right, I'm going to carry on with my presentation. We won't ask you to share that now. We'll speak a little bit more about it later. All right, I'm now going to hand over to Julia, who's going to take us through 3 cases where there was an element of fear involved. Thank you, Julia.
It's a pleasure. Thanks, Michelle. So as Michelle said at the very beginning, this is not meant to make you very uncomfortable, and it's not meant to point any fingers. These are just cases that I've come across in the last few years where I felt, gosh, this was hard, and I wonder if we would have made just different decisions if we were feeling braver and what we were afraid of, and really started to reflect on it when we were asked to do this presentation. It kind of really, it all came together at the same time that this is a problem. We are scared of making decisions and the ramifications. So really, as I talk through the cases, if you are in KZN and you recognize any of the content, I apologize. I'm not trying to blindside you at all, but I think these 3 cases illustrate the points that we're trying to make. So the first case was a newborn that had trisomy 13, but numerous congenital anomalies, and was in fact oxygen dependent. We were asked to see the child on day 7, but because we've been so busy, we could only get there on day 11. And we took the history from the mum, and essentially the bottom line is she had an antenatal diagnosis and she declined termination. She had Googled the disorder. She knows that her child won't survive. She hadn't actually disclosed that she'd had an antenatal diagnosis, and somehow that managed to get missed as the baby was retested in the nursery, which is unfortunate, but one of the things that we do see from time to time. I think mum was hoping for a different outcome. And then chatting further, she lives locally, but actually home was in the Eastern Cape. Thanks, Michelle. Michelle? Thank you. So the conversation we had with her, and this is sort of summarized, was basically, what are you actually waiting for? And her response was, I don't know, doctor. I asked them to take the oxygen off, but they haven't. They said they will, and then we will wait for 24 hours to see what happens. And so I asked, well, what do you think will happen? She says, the baby will die. I said, did the doctors tell you that? No, but I can see myself that the baby can't survive without the oxygen. And she went on to say, and because of the condition that the baby's got, the baby can't survive anyway. So the next question is, but where do you want to be when the baby dies? At home in the Eastern Cape. Thanks, Michelle. And effectively what happened that evening is we discharged the same day. We chatted through all the ramifications. What will happen if you take off the oxygen? The baby could die very quickly. The baby might die on the way home. How are you going to get home? What transports have you got? They were able to organize private transport, because we said we wouldn't be very comfortable if she was going in a taxi for the baby to die in the taxi. There's an incredibly emotional conversation to have, but actually enormously practical. And I kind of went back and why did they want her to wait for 24 hours before they let her go home, knowing that the child would probably die in hospital? And there was no sense of, well, you can actually go, but be aware that the child might die in the transport on the way home. And I think it's kind of really stressful because this poor mum was stuck there and the doctors weren't raising it. And she had sort of raised it and they'd said, well, we'll wait 24 hours and see what happens. So end of the day, she got near home, but unfortunately the baby died in the car, but she was holding the baby when the baby died. So when I chatted to her after that, her response was, I'm so grateful that I got home and could grieve surrounded by my family. The doctors and nurses did everything they could. I could see how sad they were, and I think scared to let us go, knowing what would happen. I think it's very hard for them to tell the truth when the truth is so terrible. And I think that was when I first started thinking about this concept of fear and what it means. Thanks, Michelle. So if we think about the impact, what were the possible sources? Can you go back one, Michelle? I just want them to pop it in the chat. So if we just think about the situation, what was there fear involved? And was there what was the source of fear? If you can just sort of pop it in the chat, what do you think sort of was the disconnect there, if you don't mind popping it in the chat? Or was there a disconnect, or was it, am I making it up? Any thoughts at all? Uncertainty, yeah. The fear of being responsible for death, that's really, I think that's a big one. Yeah, the fear of the unknown, losing control, being the bearer of bad news, absolutely. Yeah. So many reasons. So you can move it on, Michelle, if you want to. Fear that the mom would not be able to handle dealing with the death outside the hospital. Yeah. Thanks, Michelle. You can bring up the fear of retribution of the mum coming back and blaming, loss of control, the grim reaper. The doctors hadn't made a discharge plan and were likely afraid that they had sent mom without a proper plan. Okay, accountability, very much so. Great, thank you for all of those contributions. So these are the things I've got. Maybe the fear of having that difficult conversation. I think you've covered that the baby would die on the way, that there would be comeback if the baby died on the way, like what will happen? You know, will we be in trouble? Will we be sued? That it would be too hard for the mum, and then our colleagues will judge or criticize us. Yeah, and then also making sure that mum is safe before delivering them, before discharging them, absolutely, because she had just delivered. Very, very reasonable. So let's think about the impact then, Michelle, if you can just move on. This was my last thought. Maybe we were too busy to make the time. We know how NICU can work. It is pumping, it is busy. So maybe sort of hiding behind the fact that we don't actually have the time. And I don't mean to sound glib or facetious when I say that. I think it really is hard to find the time, but these conversations are important and they do take time. So let's think about the impact of not having the conversation. It really removes the parent's autonomy. It assumes that she is not capable of making that decision for herself. The baby then dies in hospital. The mom is alone when the baby dies. They've then got to consider the cost of transferring the body, not only to home, but to another province for the burial. The rest of the family would never have a chance to see the baby either dead or alive, only after death when all the changes have taken place. Then just thinking about the cost to healthcare, and then the toll on us, and I think this is something we don't think about often enough. There is an enormous emotional toll of seeing a child every day and a mother every day that we know is not going to do well. And it takes a lot to go up and not kind of rush past them, and you don't want to keep saying or breaking the bad news over and over again. So getting patients discharged correctly can have a huge impact on us positively, that we no longer actually have to face them every day. They are gone, we've made a good decision. And it's not always easy to know, but there's also the hidden toll of not knowing if we did the right thing. And I think that can be a fear, but it can also be an impact. If a baby has died in hospital, we can justify it to ourselves, oh, it's the right thing to do, but without really knowing that we were acting in the best interest of that child or that mother. Okay, Michelle, thank you. So the second case was a 4-year-old that was diagnosed as being terminal. The clinical condition is not really relevant as such. And we saw the child in the central hospital, and we'd done full counseling. We'd written an advanced care plan. We decided with the mum that it was intervention level 1 for comfort care only. We discussed where she wanted to be, and she didn't want to be at home because she felt she couldn't cope with the 4-year-old, but she would rather be in hospital, and she wanted to be closest to home, so her district level hospital, because her family were there. And she really wanted that, and we were very clear, and it was a long conversation, and off she went. Unfortunately, in KZN, and I'm sure it's the same in other places as well, sometimes we have to have a 2-tiered discharge process where they get transferred to a closer hospital and then from the regional hospital back to base because of the transport routes. It's kind of how it happens. And she'd specifically said, I don't want to get stuck at the middle hospital. Please, can we make sure that I go to the district hospital? Unfortunately, the child got stuck at the middle hospital, and the mum didn't phone us, and I was quite sad about that. And I've had to reflect on why she didn't let us know. Maybe she'd changed her mind. Maybe she had a different outlook. Maybe the counseling was different. I don't know really what happened at that regional hospital, but I do have to wonder why the child never got back to the district hospital. And I haven't had a full chance to ask all the role players, so I apologize if any of you are on the call, because that's still on my list of things to do. But it did make me think, well, why? What happened? So if we can have the next slide. And I just wonder if it wasn't that the child was too sick, that it's really difficult to discharge a very, very sick child to a district hospital knowing that they're going to die. That again, that fear, what if the child dies on the way? What if the parents blame us? What if? But I just want to think about the impact of all of this on us again. When we've got a certain set of ideals and values and beliefs. And that is how we want to practice. And I'm sure every doctor, if they'd seen that advanced care plan, would have said, oh gosh, this is mom, they've had a really good conversation. Let me rethink about this. Mom, are you sure that's what you want? Maybe mom changed her mind. Or maybe they looked at the child and they saw this very, very sick child who was going to die and just thought, we can't send such a sick child. We just can't. Maybe there's more we can do. Maybe there was a fear of letting go. I'm not really sure. But I think when we have this sort of, we want to do the right thing, we want to make sure we're getting the care that is appropriate for the child, the care that is in line with the patient's views and values and the parents' views and values. And then we're not able to, for whatever reason. So the picture here, we've got our beliefs and our values, and then what we're actually doing, how we're actually practicing every day. And if the greater the angle is between how we think we should be practicing and how we actually are practicing, whether it be because of our circumstances, because of COVID, because of any other situational, institutional problem, we call that the angle of discomfort. And that's where the sense of moral injury and moral distress arises. And moral distress is and I'll put the link to this article, first described in nurses, but really it's that experience where you've got unresolved feelings of incompetence, perhaps compromised integrity, frustration, anger, powerlessness, outrage, and sadness. And it's when we are not practicing in line with what we really believe and what we value because of the circumstance. And now it might be in the situation that the child, that there was a sense that we couldn't fix the child, that there's desperation there from the doctors. But it's really an opportunity, I think, for us to think about the way we practice and how we make those decisions and who do we listen to and why, what are we, who are we treating? Are we treating ourselves? Are we treating the patient? And really trying to narrow that angle to lessen our distress. Now, often it's not possible with COVID. We know many of us couldn't practice the way we wanted to. But are there other things like fear, inner fear, that are inhibiting us from practicing the way we know we should be? Thanks, Michelle. So the last case I just want to raise was a very, very difficult case, I think, for everybody who was involved. And this family had a rare disease, and 2 children died with the same rare disease 5 years apart. The second child, so the first child died before the second child was born. So when the second child was born, the mum knew straight away, this child looks like the other one, this must be the same condition. So she came early for care, but really it wasn't a disease that treatment is easily available at all. In fact, even in the private sector, it would be difficult to manage this condition. But 10 days before the second child died, she was seen for a specific assessment because another department suddenly said, oh, maybe there is a treatment option, but we need an assessment of this particular kind to get to before we can make that other referral. The advice that was given from the people making the assessment was, gosh, you must go for physio, you must go for OT, we'll refer to dietitian, she needs to gain some weight, and speech and language therapy as well. The advice given was completely disconnected from the condition of the child. The child died 10 days later. And it was quite obvious to anyone really thinking about it and really thinking about it, that nothing further could really be done to improve the quality of life for this child or to improve their outcome. So why, where was the disconnect? How did this happen? Next slide. Michelle, thank you. Any thoughts? Okay, good. All right. So just any thoughts about, was there a disconnect? Do you think it could be done differently? Why would this sort of disconnect occur? Natural reaction of clinicians is to grasp at straws. Yeah. We don't want to be the bearer of bad news. When we see an underweight child, we want them to go to a dietitian and gain some weight. Yeah. Any other thoughts? one of the interesting things when I went and chatted to those involved and asked, what was the reason for this, the patient had been referred and they had to see the child and make the assessment. And they felt that they couldn't argue with the senior. So the person who'd done the referring, that they didn't really feel that they could argue with that individual. Our own multidisciplinary team discussions not happening. Thank you. Our own fears. I'm sorry, I'm scrolling, trying to get through the chat. So we train not to give up. Please send messages to everyone. Okay, yeah. We trained not to give up. Absolutely. MDT discussions not happening. Our own fears and feelings of hopelessness. Poor communication again, and poor communication between departments. Okay, and yes, it might just be a simple thing of poor communication, but I think a case like this goes deeper. It is more about the fear. I didn't want to see how sick the child was. I didn't want to argue with the senior doctor. I had to do as I was told. I didn't want to experience any comeback by not doing what I was told. So I'm going to give you, there's two, I interviewed this mum and I've just got two little voice clips to play of her thoughts about what happened. So Michelle, if you don't mind clicking on the first one.
Looking back, I think in hindsight, most of the decisions that were made were not from a place of medical knowledge. I think it was from a place of emotion. The decisions that the doctors were making about my child's life was from an emotional place or to soothe their conscience.
Okay. And then the second clip is another, yeah, thanks, Michelle.
Given my experience with having two children with the same condition, I would think that I have researched enough as a parent to understand fully the extent of the sickness at hand that my child is experiencing. Knowing that I'm the parent of the child, I look after the child on a day-to-day basis. I know the temperament of the child. I know the struggles that we faced with the socio-economic conditions, the way we live, what we eat. I think doctors need to take that into consideration, that the parent has also done their homework. They need to listen and give parents more information and listen to what we have to say. Sometimes I think arrogance gets in the way, like I'm the doctor, you the patient, take what I'm giving you. But I think sometimes we can learn from listening to our patients.
Thank you. So she uses the word arrogance there. I think she was really trying that there might be this disconnect. But really, she did believe that there was a lot of emotion involved, and understandably, no one wanted her to lose a second child to the same condition. And I think so what we've spoken about is medical fear, but a big part of fear in pediatrics is this kind of the communication stuff, is being able to be brave enough to have those hard conversations, to listen to a parent and help them to make the decisions that are going to be best for them, even if they're uncomfortable and not great for us. And the impact on not only us, but on the family and the child and the extended family that get excluded when we don't sort of go there and have these difficult and I think what is one of the hard things to do is to reflect, and there is a sense of, there's a cognitive dissonance where you are presented with evidence that is overwhelming, but we cling to our belief systems because that makes it more comfortable. We need something to be true. And so often what we will do is, no, it's better for this mom to be in hospital, much better. And we convince ourselves of something because the alternative is too hard for us. The fear factor is too big. And I just want to finish my section by saying there's a lovely book called Listen by Catherine Mannix. And this really struck me. She said, I knew what was the matter with my patient, but not what mattered to her. And I think this is where if we can just immerse ourselves fully with the patient and be fully present with the parent, we might be able to manage and quell some of those anxieties and fears that we have that paralyze us to do perhaps the more difficult things, but are possibly the right things. So really just giving us a chance to think about that. And careful in the groups, but I think at times there is a fear of inadequacy when a parent knows more about the condition than us. 100%, absolutely, absolutely. Thank you for that. So I'm going to hand back to you, Michelle.
Thank you very much, Julia. So I'm just going to stop screen sharing at the moment. And I was just wondering if anybody would like to make any comments on any of the cases or to give some feedback on their reflections on this topic. I know it's always very scary to be the first person.
Michelle
and
Julia, thank you so much so far. I do see there are some hands up. It might have been from earlier on, but I'd be interested to hear if there are comments for those that had their hands up and how quickly are the hands disappearing as I said that. Okay, those that are hands are up. Would any of you like to actually make a comment, or is this related to previous? Okay, I see Alzette.
There we go. We can see
Hi, yes, can you hear me?
Yes.
Hi, hello, can you hear me? Yeah, I think it's just really very tough. I think especially coming in, I'm working a lot with newborns, and you haven't met this person or this family for the whole 9 months. And suddenly, and I've had a case now of undiagnosed Down syndrome as well. And I think it just brings to mind again that suddenly that's supposed to be the most wonderful time in any family's life. Suddenly you have to be the bearer of bad news. And I must say, I always thought the older you get, the better it gets or the easier it gets. And I must be honest, it doesn't get better and it doesn't get easier. And I see, just seeing how parents' dreams in front of your eyes shatter, and they suddenly have to get a new reality and face new challenges and things that I didn't even think would ever happen to them. So it's very daunting. I really, and especially if you're having a busy day and this pops up unexpectedly like it usually does, it really just makes you feel very sad and heartbroken and stuff like that. So yeah, it's very difficult. It really is.
Yeah, thank you very much, Alzette. I think also sometimes we're fearful of having conversations and the emotions that might evoke in the family, and our capacity to cope with that and still appear professional, you know?
Yes, absolutely.
We don't want to go there, you know? We don't want to lose composure.
No.
No, thank you so much for sharing that. So
thanks.
I see Vista Naidu.
Yeah, I just like to share the point of, most often I find that there's a fear of making the wrong decision. And I think as clinicians, we always look for validation from others that we are indeed doing the correct thing. And I think that's important, that the aspect of team decision making, where it makes it easier if the load is lightened. So if many people agree, concur on an opinion, it's more likely that that decisions will be valid and also more acceptable. So that's one thing that I'd like to put forward, that team decision making is critical.
Yeah, the sharing the burden of decision making, that's not all on you.
Yeah.
Thank you. Faisal, Carla. Faisal, are you there? There you go. Faisal, you just need to unmute.
I don't think she really will. I think her hand was still up from before.
Okay.
Okay. So we've got a
Maybe
few other
Nikisa.
comments that have come in. So there was a question from Mark earlier about the disconnect in the third case about the adequate outpatient records, and there was very good outpatient records. So that wasn't the issue. And then Sherry Goldswain says, sometimes we doubt the understanding of the parents and whether they are clear on decisions. Parents struggle to say it's okay for us to stop. They do, and it's hard. And these conversations do take time. Errol Gottlieb says, managing my fear, the child's fear, the nursing staff, and the family's fear often focuses on ensuring that the terminal management plan ensures that I'm reducing the trauma of the process of a dying child for all involved, rather than adding to it. Often easier said than done. When one on occasion receives a thank you note, then it often validates one's management of the process. Yeah, absolutely. Amanda Ryan says, possible fear of not managing overall. Individual patients, just one of a whole lot of patients who need to be managed. And so we slot them into a system that we feel we can manage. Absolutely. I think just being overwhelmed and having too much to do it makes everything so much harder. And we do have to make sure we can get through the end of the day and through a whole ward round. We do. And then fearing difficult conversations from leader, we don't really listen to what parents say and feel. And I think that is true. And I think it might be a part of the rushing and just not having the time to sit and reflect and have wonderful MDTs where everybody has an opinion, can all get together and make great decisions. So there are a lot of problems, but I hope that this kind of brings up some solutions as well.
I don't know if Nakisa maybe wants
One more hand, yes, Nakisa.
Hi, sorry. I just the difficulty in conditions where, there is a low, that children do survive at times beyond, 1 year, that there is I think it's difficult to also make decisions about, do you tell the parent that, your child might die, and, do you stop, not caring, but stop giving treatment in certain conditions. So I think that's where I feel that there is some difficulty, where some children do survive, and you're telling the parents the statistics, but you don't have you don't have control of what the outcome will be, is quite difficult as well.
So you're talking about really fear of prognosis and uncertainty. Yeah.
Yes.
Yeah. I mean, I think one of the big things that I've often seen in ICU is if we don't have a diagnosis and we can't prognosticate, then that is often quite paralyzing. But then the thing we also often see in the bereavement stage is it's rather err on the side of saying this might not go well. Because you can't go backwards if it doesn't go well, and you also kind of give a warning shot for families to prepare. We've had so many families where they say, I was completely blindsided. I didn't see that coming. And actually, when you went back and spoke to the clinicians, they said, no, we thought it might not happen, but we didn't want to say anything just in case the miracle did happen, And I think it's where there's ambiguity, I think it's really important to express that ambiguity. Sometimes you might be fearful of, you don't want to fail the family. And but you actually will fail a family if you're not honest with them and they're not prepared. I see Samantha Govender.
Hi, Michelle.
Hey, Sam.
For me, what I find what helps, or the team that we work with, is that, and I think what Dr. Naidu was even mentioning, is that to have a team decision, I think it takes somebody who has the, how can I say, the willpower to actually ask the team, what are you trying to achieve? How are you sending home this baby, or what kind of condition are you aiming to send this baby home to this mom with? Because if you talk about the morbidity of illnesses and the financial strain and the burden of disease, sometimes we need to actually ask that question, and the quality of life. And I think as a team, we need to make that decision. And if it's difficult, then sit together and weigh the options out. And even when it comes to withdrawal of care, I think when 2 people or 3 people carry that weight and assess the patient and say, look, I think we have exhausted all our medical options and all our surgical options. I think we need to focus our care and change the method of what we're trying to achieve now, and aiming for more of a quality of life versus trying to medically treat something that we are unsuccessfully treating. And I think what works best is if you are like, it's not one person, it's like 2 or 3 people assessing the patient and coming to that decision, and that same team of people going to speak to the family. So then the family knows that it's not only one person, it's many people who want to achieve the same thing for that child.
Mm-hmm. Yeah, in fact, actually, Samantha, it's unethical for one person to make that decision. Any decision to withhold or withdraw life-sustaining therapy needs to be made by more than one person. Yeah. The other thing I want to say is I have been in situations where doctors have said to the family, this is option A or option B, and they don't know what to do. And they say, what would you like to do? I think putting that burden on the family, that's really unfair. You know, it needs to be shared between more than one clinician, but also, you know, we can't put that burden on family, especially if we don't know what to do. We actually do need to come to a consensus, which might require, you know, meeting with getting an external opinion sometimes as well. And I often find that's the value of an outside palliative care team, especially in the ICU context, because people do get attached to patients. It's human, you know, especially that patient that's been in the ICU for a very long time, you know, and it becomes tough making that decision.
Michelle, I just quickly want us to go through Celeste Cox's question, because that question gives me anxiety when I read it.
Yeah.
So Celeste is saying, what if the parents are not on board with the palliative plan, or even refuse the palliation, even when you and everyone know that it's futile?
Yeah, yeah. Now we do often obviously have that situation. And just from a sort of cultural, religious perspective, I've had quite a lot of Muslim families where they do not want to do advanced care planning. It's not up to us to decide when a child dies. That's Allah. Allah's going to determine the time, and we're not even allowed to speak about that, you know. So usually in those sort of circumstances, I will often have sort of more general conversations about the principles of suffering, you know, and most families will agree that we don't want our child to suffer. There are a lot of families that will say, I'm not going to give up. And I've even had a mom who said to me when her child died, she's not dead, she's just stopped breathing. You know, so strong was her denial that this child was not going to die. And there's some families that you're not going to move past that, you know, until even after the death has occurred. Yeah, and they're difficult families to manage, and often we just really do need to have, sometimes maybe we haven't had enough conversations. Sometimes we're never going to get to that point. And what I often like to say is the child then ends up making the decision, you know. Sometimes you'll see that the child will actually, I start saying to the parents, well, we actually need to start looking at what the child is telling us, even if the child is not able to speak, you know, and you can see what's actually happening to the child. A very useful thing as well is I often draw a disease trajectory where I'll actually graphically map out, okay, the child is admitted here, the child is admitted here, the baseline is drifted here. You can see these admissions are getting closer and closer together. The child, a life-threatening event here. And then that graphic representation, it's very difficult to not see it. But I think also need to recognize that you're not going to get everybody ready. What parent is ever ready for the death of their child?
Ramola's had her hand up for the longest time.
Yes, I think Ramola, and then maybe we can move on a little.
Ramola, are you there and wanting to say something?
Hi, no. My hand was still up, should have been down.
Okay.
Great presentations. Thanks. Bye.
Thank you.
Fantastic. I just have two more slides, I think, just to wrap up the conversation, because I know our time is going, so I'm just going to share again. I also just wanted to say that it was actually my fear of dying and my fear of having bad mortality stats to present at the M&M meeting that got me into palliative care. So fear does have some good roles. Okay. So just to conclude, how do we actually overcome fear? I think most importantly, we actually need to recognize it. You know, we need to name that emotion.
Michelle, I'm not sure that you're sharing.
Oh, sorry.
I can see it.
No, you are
Oh,
sharing.
you can't. Okay, sorry.
No
I've just shared. Can we see again?
Yes, it's perfect.
Okay.
Thanks.
Sorry.
All right. No problem. So step number one is we actually need to recognize fear. Yeah, and we actually need to, sometimes it just manifests as a feeling of discomfort and confusion, and you need to name it. You know, and if understanding that circuitry also helps you to bring fear from the unconscious into the conscious. We need to reflect on it, and we also need to explore what is actually triggering me, and often it is past experiences. We actually all carry a lot of baggage with us. I think many of us actually suffer from PTSD, from medical fear, and, you know, situations as a junior doctor, moral distress that we actually haven't processed. And I think it's very, very important for us to process those memories. It's also very important to explore the situation from different angles. You know, as I mentioned, when we take the low road and we activate our primitive systems, we're actually not very objective. So that is also very, very helpful. Is it possible that we could look at things from a different perspective? Can we get somebody else in, you know, who can actually give us an objective view of what is happening? Can we ask for support? I think that is very helpful when you are feeling triggered and you're feeling fearful. All right, and I just really wanted to end with this wonderful saying that we all know from Nelson Mandela. I learned that courage is not the absence of fear, but the triumph over it. The brave man is not he who did not feel afraid, but he who conquers that fear. And obviously, the first step in conquering your fear and developing courage is actually recognizing that it is there and doing something about it. And then also, I just wanted to say that, I mean, I think I asked at the beginning how many of you had experienced medical fear. You know, we were all very young medical students at one stage, shaking in our boots in a ward round. And I just want to ask you to remember that experience and really look at one of the other ways to overcome fear is actually to create more of a culture of kindness. And actually medical students and junior interns are going to learn more from you being kind and helping them through a fearful situation than you actually putting them on the spot and asking them to account for their actions. Yeah, that's it from my side. I don't know if anybody has any final comments, but that's our presentation for today.
Thank you so much.
I just want to add to that about the kindness thing. I teach sixth years on a Wednesday, and it's always by this time of year, it's supposed to be communication skills tutorial, but by this time of the year, it's a real debrief. And yeah, I know that everyone complains about millennials, and there's a lot of eyeball rolling from more senior staff when it comes to the students. But the truth is that we haven't really evolved hugely as a profession. We still, it was done to us, we'll do it to them. We you know, and I know the students can drive us all crazy, but I do think what Michelle's point about kindness is so important, because they watch us, they learn from us, and we need them to be better, and we need to do better, all of us, every one of us. So yeah, good luck, and thank you for having us on tonight.
Thank you so
Sprinkle
much.
kindness like glitter. Says Linda.